Hello friends, myself Siddharth Chauhan. Welcome to Easy Medcam. So today we are going to discuss about the hypertension. So mainly I'll be discussing about the medicinal part, the pathophysiology and the pharmacological part, and all the drugs which are used in the hypertensive crisis or types of hypertension I'll be discussing in the next video. So this video comprises only the medicinal part of hypertension. So what does actually the hypertension means? The hypertension or a high blood pressure occurs when your heart has to take extra effort to pump the blood, causing damage to the arteries in the process. And the normal blood pressure, which is ranging from 120 130 mm of Hg, which is has to be systolic, and 80 to 90 mm of Hg, which is to be diastolic. If it goes beyond these readings, then we can diagnose it as a hypertension. So how to understand what is actually the hypertension is? We already know that from a physiological series that we have two types of readings, such as a systolic and the diastolic one. So the systolic, which mainly depends upon the cardiac output of the heart. If the cardiac output increases, the systolic blood pressure will obviously go increasing, and if the total peripheral resistance mainly decide the diastolic blood pressure. So we already know that the cardiac output is a multiplication of the stroke volume and the heart rate. So if anyhow the stroke volume is decreased, the heart rate will increase in order to compensate the decrease in stroke volume. We already know that from the compensatory videos that cardiac output is a multiplication of stroke volume in the heart rate, and the total peripheral resistance mainly depends upon the resistance offered by the arterioles. If the arteriole will constrict, the resistance will increase, and if anyhow the arterioles will dilate, or if we are giving any drugs to such as the arteriolodilators, so we can decrease the total peripheral resistance in order to decrease the diastolic blood pressure. So mainly we are having two guidelines, which is the Joint National Committee 7 or 8 and the American Heart Association, which determines the guidelines, which gives the guidelines how to diagnose hypertensive patient. So we already know that in both these guidelines the normal blood pressure is same, which is 120 by 80, which means the diastolic blood pressure should be 80 and the systolic one has to be 120 mm of Hg. Both the committee has the same normal blood pressure 120 by 80, but the Joint National Committee 7 or 8 in 2015 has recommended this guidelines. So according to this, the elevated blood pressure has to be 140 by 90 mm of Hg, which means the systolic has to be 140 and the diastolic has to be 90 mm of Hg in order to diagnose a patient with the hypertension. And the American Heart Association has declared it as it declared the slightly less value of the systolic one, which is to be 130 mm of Hg for the systolic blood pressure, and it has to be 80 mm of Hg for the diastolic blood pressure. So Indian guidelines also follows the American Heart Association guidelines, which means in order to diagnose a patient with the hypertension, the patient has to have 130 mm of Hg as a systolic blood pressure and 80 mm of Hg for the diastolic blood pressure in order to diagnose a patient with hypertension. But the only one reading will not specify whether the patient is hypertensive or not. We have to take 2 or 3 readings consecutively after 5 minutes. If the reading signifies the same value, we can diagnose a patient with the hypertension. So there are 5 categories of the blood pressure. We know that the normal is 120 by 80 milligram hydrogram, and elevated is to be the systolic has to be in the range between 120 129 milligram mm of Hg, and the diastolic has to be less than or equal to 80 mm of Hg. And the patient is named is to be in the stage 1 of hypertension if the systolic is in the range between 130 139 mm of Hg. These guidelines is according to the Joint National Committee, which is JNC 7 or 8. But this guidelines according to American Heart Association as well as the Indian Heart Association this hypertensive patient is to be diagnosed hypertensive when the reading comes out to be 130 by 80 mmHg. So what are the clinical significance or the clinical symptoms and signs which tell us about the patient is under the hypertension or not? So the patient is having the headache, he can have a shortness of breath, he can have a nose bleeding, flushing, dizziness, chest pain, and the visual changes. In order to diagnose the hypertension, we can do the ophthalmoscopy also to check whether any hemorrhagic lesions on the retina are there or not, in order to diagnose the hypertension. But this is when we are not getting a value, we are not able to check the patient ambulatory. Okay, so visual changes can be there in the patient with hypertension. So we know that types of the BP measuring conditions, we have so many environment in order to check the we have so many environment in order to check the BP, such as the office BP, 24 hours ambulatory BP, and the home BP can be there. So office BP, it might be generally high due to the white coat hypertension. In the office, generally the patients are more anxious about seeing the patients and about seeing the doctor. They becomes more anxious, so the office BP will generally be 140 by 90 or more than that. But this does not signify that the patient is hypertensive or not. So we can do home BP. We can ask the patient to check the BP of his or him in the home by the electronic device. We can ask the patient to do that. So if the three consecutive readings comes out to be 130 or 80 mmHg or in these range, so we can diagnose the patient with the hypertension. So this is the home BP, but we can also do the 24 hours ambulatory BP, which means it can be the daytime average as well as the nocturnal average or night average. Generally 120 by 70 mmHg in the night, or the average of the nocturnal average 24 hours ambulatory BP can point towards the hypertension also. So 120 by 70 average in the nocturnal time, the patient can be having a hypertension, might signifies or can point towards the hypertension. But the daytime average has to be 130 by 80 mmHg. So these are the values which we have to look upon. So what is the algorithm, how to start the medical treatment, or what are the lifestyle modification which has to be recommended to the patient for the hypertension, in order to make the life of the patient more comfortable. So these algorithm has to be followed by the physicians. So if the patient is having a normal BP, we should not start directly the medical treatment. We have to ask the patient to do the lifestyle modifications, such as both decrease in body weight. So there are studies in which the lifestyle modifications or the modification in his lifestyle can decrease the maximum up to 20 mmHg. So this is a great value which has to be achieved by the patient if the patient is doing decreasing its obesity. Okay, we can ask the patient to do the physical activity as well as the mental, look upon his mental status also. So if we can do so many things for the physical activity, but for the mental status we can ask the patient, we can give or small doses of tranquilizers to the patient in order to check the mental status of the patient, in order to check about the mental status or mental well-being of the patient. We can also ask the patient about the salt restriction diet, salt restriction, and we know that we should know that the normal person, the salt intake has to be in the range between 6 to 10 gram per day, and for the hypertensive patient it has to be decreased, which is 2.3, or in these range only, 2.3 grams per daily. Or if the patient is more severe hypertensive, or the patient is in the stage 2 or the hypertensive crisis, we have to ask the patient to go for zero point 0.3 to 1.3 grams per daily of the salt intake. So salt intake restriction has to be done by the patient. So if the patient is in the normal BP, we have to ask the patient to the lifestyle modifications. If anyhow the patient is in the pre-hypertensive stage, still we have to ask the patient to do the lifestyle modifications. We are not going to prescribe any medicines to the patient. If the patient is in the stage 1, we have to check whether the patient is with any other comorbidity, such as a pre-diabetic one. The patient can be the patient of the diabetic mellitus, or any cardiovascular diseases can be prevalent also. So if we have to check for any other comorbidities, if the patient is in the stage 1 of hypertension. So if the patient is in the stage 1 of hypertension and with any other comorbidities, we had to ask the patient to do lifestyle modification instead of taking any drugs or medicine. We are not going to prescribe any medicine for the stage 1 patient with any comorbidities. But if the patient is in the stage 1 and still in the stage 1 with comorbidities like cardiovascular or any diabetic patient, we have to go for the medical treatment. Still the lifestyle modification is anyhow no going to do the advantage. We have to go for the medical treatment for this patient. So we'll be discussing what all medicines are going to prescribe by doctors to cure the stage 1 hypertensive with comorbidities. So if the patient is in the stage 2 of hypertension, we have to go for the medical treatment. Definitely we are going for the medical treatment. Lifestyle modifications are not going to give any advantage. For the hypertensive crisis, definitely we are going for medical treatment. So this is the algorithm which signifies or which tells about the how to deal with the patient by the doctors. So for the treatment purpose, we can check of the age of the patient also. If the age of the patient is less than 50 years, we can prescribe the ACE inhibitors, such as the angiotensin converting enzyme inhibitors. We can go for that. But if anyhow we know that there are so many adverse effects of the ACE inhibitors, such as the dry cough, and captopril is an intravenous drug which is the ACE inhibitors with so many side effects. So if these side effects are not tolerable by the patient, we can go for the angiotensin receptor blockers, ARBs, so with less side effects. And mind it, we should not combine both these drugs, or we should not give the combination of ACE inhibitors plus ARB to any patient. This we have to check. And if the age of the patient is more than 50 years, we can go for the calcium channel blockers, or we can go for the diuretics also. So in this diuretics, mainly these calcium channel blockers are dihydropyridine types, such as the dipines type, such as amlodipines, nifedipines, nicardipines. We can go for that amlodipines. Initially we had to start for the half dosage, and after still the patient is not recovering, we can go for the full dose of amlodipines, like that. But this is the next step which we have to go for that. But for the diuretics, we have two options, right? we can go for the loop diuretics as well as the thiazides diuretics. But in order to go for the loop diuretics, we should make a point that we already know that the loop diuretics is a short acting and is very strong, and with the loop diuretics such as the furosemide, we had to add the spironolactone, which is the aldosterone receptor blocker also, but we are not going for that spironolactone in the initial treatment. So we are not going for the loop diuretics such as furosemide. We are going with the thiazides such as hydrochlorothiazides. We can go for that because it is less strong and long acting also. So we can prescribe only one tablet per day. If we are prescribing the furosemide, might be we are going with the 2 tablets or 3 tablets per day, but we should not go for the loop diuretics for the initial therapy. Okay, anyhow, we are not going with the furosemides. Thiazides are the best drugs, best diuretics, which will control the hypertension in the hypertensive patients. So what all combinations for the initial plan, and after the initial plan is not done, we can go for the further plans also. So for the initial plans, we can go with the ACE inhibitors plus calcium channel blockers. Such as the if ACE inhibitors are not tolerable, we can go with the ARBs. So that for the initial purpose, we can go with the ACE inhibitors or ARBs plus calcium channel blockers. If anyhow the patient is not recovering, we can go after the initial plans. We can recommend the diuretics also, such as the thiazides instead of furosemides. So the 3 combination of drugs such as the ACE inhibitors, calcium channel blockers and diuretics are, all these 3 drugs are recommended if the initial plan of ours are not doing well. Okay, so although after initial introduction of all these 3 drugs, still the hypertensive patient is not curable, so any BP is not coming down. So this is the point where the doctor has to diagnose the patient with the resistance hypertension. So what does the resistance hypertension means? After giving all the combinations of drug, all the 3 combination of drugs such as the ACE inhibitors, calcium channel blockers and diuretics, still the patient is not recovering. So these patient or this hypertension is a resistance to all these drugs. So this is the time where we had to start with the aldosterone receptor blockers such as spironolactone or eplerenone. So spironolactone, we know that the spironolactone from the pharmacological lectures, with that spironolactone is a drug which is having an adverse side effect of gynecomastia. So if the patient is male and we are not going to aggravate the patient with the gynecomastia, so we can prescribe the eplerenone instead of spironolactone with the same effect, or we can cure the patient of hypertension such as the resistance hypertension. So this is all about this video. I'll be going further about the hypertension and the medical parts also, and all the pathophysiological pharmacological aspect of hypertension. So that's all for this part of the video. Thank you.